All right, welcome back to Stop Feeling Like Shit. I'm Tiffany, and this is Joe to the second part of our sexual dysfunction conversation, the women.
Yep.
A little bit more complex because you're looking at more than just one area, I guess.
Yeah.
That would kind of be the way I would say it.
Yeah.
So the things to point out go the same, 1, 2, 3. We can start with the psychological portion of that first.
Right.
And the conversation is fairly similar to men, where if you are constantly under stress or duress, obviously you're not going to be successful in a sexual experience. If you're feeling like you're running from a bear,
Yeah.
Same idea.
If you don't like the person you're with or you're having obligatory sex, that obviously does not help. I think we hear about that a lot, especially as women transition to perimenopause and menopause, which we'll talk about the endocrine component a little bit later, where they're like, oh, I'm
doing this because I have to.
I'm doing this for my husband or my partner. Like, I don't really care about this. I'm just doing it because they want it. Like, that's obviously not great in that regards.
Yeah.
The lack of desire is a problem too, which we'll touch on in a second. But there are a fair amount of patients that are like
big.
Yeah.
In that scenario.
Yeah, there's a fair amount of women that do have obligation sex. The medication interaction is definitely plausible for women. The same things hold true for psychiatric drugs that we talked about with men. I don't necessarily see the vascular drugs be as impactful, although it could impact things like clitoral engorgement and things like that. Birth control is a huge drug interaction for women that we see a lot.
Like the biggest one.
Yep. And that primarily is a mechanism of suppression of, hypothalamic pituitary ovarian axis, and primarily shutting off testosterone. Now, testosterone is not unilaterally ovarian sourced, right? Some of it's adrenal source, some of it's made in peripheral tissue, but at a minimum, we're going to see a pretty aggressive reduction in testosterone in women with birth control for a prolonged period of time. And that's impactful to libido and sexual desire, but it also impacts some of the function of tissue itself.
Yeah, right? I was going to say localized specifically. If you lose hormone, you're losing things like positive stimulation to the clitoris.
Yeah.
You can experience vaginal dryness, things like that.
Yeah, so the testosterone is a big piece of that as well. So drug interaction is definitely a big issue. I'd say the two biggest drug interactions that we see with women is going to be the SSRI drug class and then oral contraceptives. Like those tend to be the primary killers of libido and sexual response. The SSRIs are pretty problematic for anorgasmia, where women they just can't climax no matter what they do, whether that be from vaginal penetration or clitoral stimulus. It's just a complete non-starter, right? Which of course can negatively affect libido as well, because it's like training.
Why am I doing this?
Training for a race and then never running the race, right? That's kind of pointless. So, I mean, I guess one of the things we talk about first is, the changes in the endocrine profile for women is quite a bit different than it is for men.
Yes.
And one of the things that we see as well is obviously the ovaries will fail. For men, it's atypical. We don't see men very often with no testosterone. We just see them with less testosterone, right?
Yeah.
But what we typically see for our female patients, and there's anomalies to this, right, is we don't see that sex hormone output tends to drop simultaneously. That is, perimenopause is not
like it just goes and then drops off a cliff.
And falls off a cliff. So, so we'll see transient changes in ovarian hormone output as women transition to perimenopause, where they may still be cycling, but hormone secretion is not always the same. A lot of times we see testosterone drops out in women first. And we see that a lot of times in the 30s. Part of that could be ovarian. A lot of that is changes on the adrenal androgen profile, where secretion of things like DHEA starts to drop more aggressively out, and that downstream reduces androgen values. So, why does that matter? Well, one, sexual excitation. Like we said, it has the same neurochemical properties to it that it does for men. Now, women won't have the same amount, but it still does all of the same things.
Right.
It's exceptionally important for localized tissue health, right? So it's going to impact clitoral tissue health. So we may say, like with long-term oral contraceptives, maybe the clitoris is atrophied, less nerve dense, but it also impacts a tissue that's called the vulvar vestibule, which is a very testosterone-dependent tissue as well. We'll talk about it a little bit more in a second. So I'd say the oral contraceptive is one of the causes we see in sexual dysfunction a lot with younger women, because we see, I started birth control when I was 16 and now I'm 30 or 35, right? So
been on the same one the entire time.
Right. So we've seen those negative effects on libido from a sexual desire standpoint, but we've also seen changes in local tissue function and health as a response to sexual stimulation, right? The other things that we'll see, obviously, progesterone a lot of times will start to drop second, estrogen will drop third. But when we look at sexual dysfunction for women, obviously libido is a pretty big piece to that, right? And we talk about for those reasons that they can hit. But we see a lot of localized dysfunction, and a lot of the localized dysfunction gets missed or mismanaged for women. So when you see women, especially as they get into perimenopause and menopause, it seems like all of their sexual dysfunction is kind of pigeonholed into a lubrication issue, right? And what are the options that a lot of traditional docs use for that? Well, they're using, either, your water or silicone-based lubricants, or you will see, like localized estradiol, where they're going to use, an estradiol cream or an estrogen suppository, right? And that will aid with mucosal function and it helps with lubrication. But for a lot of these female patients, lubrication isn't necessarily their issue, or it's not the only issue. So what we see a lot is vestibulitis or vestibulodynia, right? So vestibulitis the vestibule is an exceptionally nerve-dense ring near the vaginal entrance, right? And outside of the Grafenberg or the G-spot, that's probably your most nerve-dense tissue with sexual penetration. And that tissue is exceptionally testosterone dependent, right? So we can see that long-term lack of testosterone in the area can cause dysfunction at the vestibular level, which makes penetration exceptionally uncomfortable. And a lot of patients will notice it feels like it's burning, or I feel like I'm tearing with any sort of penetration, which obviously is an exceptionally negative response to sex, right? It blunts nerve response. And now other things that contribute to that outside of testosterone is anything that's neuroinflammatory down there, right? So recurrent yeast infections, bacterial vaginosis and things like that. Anything that will cause inflammation in that localized area can also cause vestibulitis or inflammation of that tissue. So,
which, fun fact, the vagina also has a biome like your gut does. So if that's off balance, then everything is crazy.
That can be a problem as well. So a lot of times we'll see localized sexual dysfunction. A lot of times it's the absence of testosterone for a long period of time, where we'll see clitoral sensitivity reduces, vestibule function reduces, vestibular inflammation tends to be more prevalent as well. So now not only is penetration exceptionally uncomfortable, but sexual response is blunted. So now it's like, well, penetration hurts and clitoral sensitivity is non-existent. So the notion of an orgasm has been gone for 10 years, right? Which is obviously not awesome and is going to impact sexual desire pretty aggressively as well. Right. One of the things that was interesting as well, and I may misquote this, a doctor named Irwin Goldstein, who is fairly high up in the International Society for the Study of Women's Sexual Health, that I did some training with decades ago. It was his belief on his research and study as well that as women go through menopause, that he found, especially after the age of 50, that it seemed like systemic delivery of hormones to localized tissue in the urogenital region tend to be much, much worse. And I can't remember if that was a vascular mechanism or not, but he found that a lot of patients post-menopause, especially if they had lacked testosterone and estrogen for quite some time, needed not just systemic hormone replacement, but also needed localized administration of testosterone and estrogen to that tissue to actually get the receptors back online, so that the receptor delivery from systemic circulation got better. So we can even see some women that do systemic hormone replacement that libido comes back online, but maybe local genital response is still lacking a little bit. And sometimes the addition of a small amount of testosterone that's delivered locally or estrogen will actually start to kick receptor function back online, and they get a really good response. So we do see that a fair amount with patients that have done like the estrogen only vaginal delivery, where they're like, lubrication's good, but sex still hurts. Okay?
Right.
One of the other things that we can see a lot with that as well is you can see hypertonic pelvic floor dysfunction, where basically the pelvic floor muscles are overly tightened or contracted all the time, and that can cause a lot of difficulty with penetration as well, make sex exceptionally uncomfortable. That's something that generally is treated with pelvic floor therapy, right? And there's all sorts
physical therapists for that specifically.
Right. And one of the ways we see a lot of that you can kind of differentiate, causality with that. Mm-hmm. If somebody's dealing with vestibulodynia or vestibulitis, a lot of times what you'll see is total circumference discomfort with penetration, where yes, all penetration hurts, and it kind of hurts everywhere. I feel it in every part of the vagina, and that tends to be more vestibular. With hypertonic pelvic floor dysfunction, it tends to be more specific to the posterior wall of the vagina. So when we're trying to piecemeal out, as far as where is this coming from, is it a pelvic floor issue? Is it a vestibular issue? It's kind of, where do you feel the pain, right? Is penetration uncomfortable everywhere, or is it specific to just the posterior vaginal wall? If it's posterior vaginal wall specifically, that leans more into it being more pelvic floor related. However, both can certainly exist simultaneously, right?
Yep. And then there can be other complicating factors like endometriosis and things like that.
Yeah, all sorts of things.
Which we won't touch on necessarily, but there is the other complicating factors.
Right. You can even get things like lichen sclerosis, which causes the vaginal opening to actually atrophy and close over time. It can influence the anus as well. And that obviously is a mechanism of physical tissue tearing and things like that. Mm-hmm. So there's a lot of things that can go on in that regards, but generally most of them are treatable. Mm-hmm. Okay. Estrogen is a big piece as well. That's more blood flow and mucosal barrier function in that regards. Mm-hmm. So that's where lubrication tends to be obviously a little bit more specific of an issue. If that's the problem, women may notice other urogenital changes as well. So they may notice that they're feeling more dryness, but itching, irritation. We may start to see higher propensity for negative bacterial changes and things like that. So estrogen's a big piece of sexual function as well. But really, total correction, just like it is for men, requires a more thorough evaluation. You kind of need to know what the endocrine profile looks like, what the metabolic profile looks like, what drugs are they on that may be impacting it, and then really getting into the nitty gritty is if they're having discomfort, does it feel like a lubrication issue? Is it a burning sensation? Does it feel like there's tearing of tissue? And where does it hurt specifically in the vagina itself to actually make all the right treatment choices in that regards.
So what other treatment options do we have?
Right. So we do obviously hormone replacement therapy. That's kind of first line intervention. So first line intervention, hormone replacement. If they don't do well with systemic therapy alone, that is everything else gets good, but they're still having local genital dysfunction, then we may use localized therapy as well. Very small dose of like a Vanny or a Vesipro cream that's safe to apply to that mucosal barrier. That's a combination of testosterone and estrogen to get more of those hormones directly to that local tissue. We also do sexual rejuvenation procedures for women, just like we do men. So just like we talked about allograft enhancement or stem cell enhancement or PRP enhancement, you can do the same thing for women. Generally that's done clitoral head, either side of the urethra, because it also helps with urinary incontinence, and then in the intravaginal wall. And that's more of a sexual health rejuvenation procedure where we're trying to actually get that tissue that's been metabolically dormant or damaged to actually recover and heal. PT141, like we talked about for men, which is a peptide, that seems to help a lot with sexual excitation and orgasm potential. So that seems to be really good for sexual function. There is a drug that came out, I don't know, about a decade ago that was called the female Viagra. Efficacy was not great and it really took off. I can't even remember the name of it now. But patients did not have a great response beyond clinical trials. You couldn't have a beer or an alcoholic drink if you took it either, which people have sex more when they're drinking. It just kind of is what it is. So that one never really took off, right? And with the O-shot, or allograft enhancement, a lot of times patients may do Kegel exercises or use Kegel balls or anything with it. That helps with blood flow, stimulus that area, and then obviously returning vaginal tonality as well. Pelvic floor therapy is a great option as well, specifically if somebody has uncomfortable intercourse. And those are actually a little bit easier to find. Now, there's different levels of how invasive that becomes. Some people, it's just external exercises that you do. There are some pelvic floor therapists that are more specialized that can do actual intravaginal, manipulation of the pelvic floor. It doesn't seem to be exceptionally prevalent anymore, but there were some therapists that actually used to do that. You'd have to have an exceptional level of comfort with your therapist if you did that. We don't do that here, obviously. We don't do that here. But just like it is for men, we need to address all phases, right? We need to address the neurochemical profile. We need to address drugs that may be interacting. We need to address the vascular component and then the endocrine component, right? The endocrine component's a big deal for women because once you go through menopause, the ovaries fail. Like they're done, they're not making anything. So it tends to be a super big piece is actually getting testosterone and estrogen and things like that therapeutic again. Because it does seem that if we don't do that, a lot of those other modalities have limited efficacy because those hormones are so important for the health of the tissues.
And the last thing that you didn't touch on is females actually can take Cialis too. Yeah,
women can take Cialis as well. So we've done some low-dose Cialis with our female patients, and that does help with general arousal. I mean, it does seem to improve like clitoral engorgement and blood flow and things as well, and we get more sexual sensitivity out of that also. So, but that's, again, the caveats for men would be the same that they are for women. It's kind of a low-level intervention, vasodilation, helps with circulation and blood flow.
Metabolically healthy patients who are well-managed.
Right.
Could have success with that.
Could have success with it. So
hormones play a much bigger portion for females than for men.
Yeah. Well, no. They play an equally big role.
Equally amount, but it's definitely the thing you need to look at.
It seems like if we don't fix that with men, if they don't fix the endocrine profile, sometimes they still get some benefit out of those other interventions.
And otherwise, you could just do Trimix.
Yeah, or you could do Trimix. For women, it does seem largely like if we don't address the endocrine profile, it's going to really blunt how effective those other modes are.
Yeah.
But again, sexual complex for women is complex, right? There's the status of the relationship, there's the neurochemical response, there's the vascular component, there's the endocrine component, there's the local tissue health component, there's getting into, like you said, is there a propensity for abnormalities in the vaginal microbiome? Do they have frequent BVs, UTIs, and things like that? All of that stuff matters.
So the stars must align for everything to be perfect, and everything will be great, and then you'll have an orgasm.
Yeah, yes, but we do see a pretty good response to care with a lot of these patients.
Yeah, we do.
Yeah.
So the most important thing is obviously finding somebody who is able to see that full spectrum, making sure that they're able to test the hormones, being able to tease out all of those concerns and symptoms. So you want to make sure that you're picking somebody who's specialized. And if we don't do something that would be helpful for you, we obviously would refer you to somebody who does.
Yeah, like we'd refer out for pelvic floor therapy and things like that. But most of those services are things that we handle all in-house.
Yep.
So, and I think there's value in that. You don't want to go to 4 different people for the same problem.
Well, especially because that's a sensitive subject. You don't want to just like keep going to the same person and be like, and this, and this, and this, and this.
Yeah. You can't fix it yet.
It's not fixed.
Yeah. So, anyway, I don't think I have anything else to add on that. Do you?
No.
No.
All right. And that's that.
Okay.